the rational antibiotic choices for complicated UTIs. I am not going to any description of complicated UTI. Professor Bhaskar has already mentioned that part. And it has been nicely told about. And very good day to all. Thanks for inviting me in UROGRIPP. And it's a pleasure for me to share my experience. Last year and now also we are fighting COVID-19 pandemic. But we might have forgotten that we are having another pandemic for many years. We are fighting, and probably now we are losing the battle. And that is the battle against antimicrobial resistance. And my talk, I will tell you the global scenario of antimicrobial resistance and in India, worldwide and in India, what we are having the challenges, what are the common organisms we are facing, and what are the resistance pattern, and how to manage rationally. The term rationally I put, but I know that it is very challenging because sometimes when you have no choice, you cannot be very rational. But still, just now, as Professor Bhaskar mentioned, that we should not come under the pressure of prescribing antibiotics. And it all started with this man who discovered antibiotics in 1929, Alexander Fleming. And in his speech, he mentioned that there is the danger that the ignorant man, I highlight, bold, may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug, make them resistant. We have almost coming 100 years after that, and we know that the words told by that great man is becoming very true. At present, if you look at the estimates and predictions of antimicrobial resistance, you can understand that though we are handling COVID-19, all attentions, all resources, all efforts are targeted towards fighting against COVID-19, but AMR crisis alongside with COVID-19 is also very challenging. AMR currently kills approximately 700,000 people each year, and it may result in 130,000 more deaths in this year. It is neglected, unattended, and we can predict it to increase to 10 million deaths per year by 2015. And if you see that cases and situations of COVID-19, and along with that side by side, if you look at AMR, we are in a bad situations because we are highest numbers in COVID, almost in the highest numbers of COVID-19 as well as in AMR. The AMR timeline in India, this is the timeline when I have started my work and put my interest into following up AMR in India. I found the happy days were 1980s, when we could treat patients with third generation cephalosporins, and we used to think that that is the best available antibiotics that time. But we lost that by 1990s. We developed resistance because of ESBL, and then we had vancomycin resistance enterococci by that time. And I still remember that time, that is the junctions time of between my student life and my working life, 1990s to 200, that period, the 10 years, we had few antibiotics like BLBLIs and carbapenem being launched in the market. And at the same time, we have noted that carbapenem slowly started gaining resistance along with vancomycin and linezolid resistant staph, and VRE was still under 2%. The period between 200 in this millennium, first 10 years of this millennium, which I find very tragic. We lost many antibiotics. We lost almost BLBLIs, which were having more than 90% resistance in many places. Carba resistance has increased. MRSA number In some places, it is more than this, but usually it is 40 to 50% in any tertiary healthcare center. VRE number of vancomycin resistant enterococcus, it has increased. And now we are getting launched with the newer antibiotics, colistin, Tyg, Mino. Along with the COVID pandemic, when it is going to be started, we might not have noticed that we have reached almost post-antibiotic era, where we have lost almost all antibiotics which are available with us. This is an antimicrobial surveillance network which was started in India as a national to develop the national antibiotic policy. It has been started in a few years back, and we are a part of that. We are a regional center, and I will tell you their data, January to December 9, 2019, what we can find out, and you can see that E. coli, which is the most common bug you face in your setting as a urologist, and urinary tract infections, OPD, you maybe most of the urologists or nephrologists, they in a urinary tract infections with E. coli in the patients coming in the outdoor, they try to give ciprofloxacin, norfloxacin, any quinolones. You can understand the sensitivity is only 27%. So it means that out of 10 patients, 7 may not respond. If the patient goes back to the ward and you try to have third generation cephalosporin, if you see the sensitivity pattern, it is almost negligible. Most of the third generation cephalosporins we have lost because of ESBL and AMC. If you go to the ICU, we go to the BL-BLI combinations, and it is out of every 2 patients, you may lose one because there is no, it may come out resistant. If same scenario you can have with Klebsiella. I'm not going in details, but Klebsiella, the ciprofloxacin resistance, so it is the sensitivity, and you can go to the cefotaxime, and then you are left with now meropenem and colistin, which we generally don't want to recommend, but we have no other choice in serious patients in ICU with a Klebsiella infections with complicated UTI. Maybe you are looking for meropenem, and in that case, carbapenem, any carbapenem you can looking for, and you can understand that out of 10 patients, maybe 3 may not be responding. Enterococcus, and gram-positive cocci, which is a common urinary tract pathogens. 2 species, Enterococcus faecalis, Enterococcus faecium. Again, you look at the, if it's a pediatric patient, definitely, and it has come to the OPD, outpatient department with urinary tract infections, maybe you are trying to do with ampicillin, and you can see that it is still sensitive. But as it goes towards the ward and then towards the ICU, you definitely will not try with ampicillin. You may try with ciprofloxacin, but it is again disappointing. Same is with Enterococcus faecium. You may not be trying with these antibiotics once it was tried. Then you may go to higher antibiotics in patients with ward and patients in ICUs. And there you can have, still we have antibiotics for gram-positive. They are working, but definitely the antibiotic resistance is creeping up. In future, we may lose few antibiotics which we are using indiscriminately nowadays. I will tell you the scenario in Kasturba Hospital, Manipal. It is a tertiary care hospital. It has almost 2,500 beds. It has more than 10 ICUs, many HDUs, and we usually treat patients who are very critically ill and who are usually referred. So you can understand that when they land up to Kasturba Hospital, they already have received a lot of antibiotics, and when the cases has become complicated, they are referred to us. So we don't have much choice, and we try our best. And what the sensitivity pattern we can see here, I can tell you if you look at the urine from urine sample, this is a 1 year, we have analyzed, and we have found that the patients which are in the ward and which are having urinary tract infection, it may be complicated or uncomplicated. In the ward patients, but they have no, they are not very serious. Definitely they are in the ward and their blood is still sterile. It means they have not developed urosepsis. In that case, can we use ampicillin? No. Or can we go to quinolones? No. Their resistance pattern is too high. If you can see that this is the sensitivity pattern, what we are showing here, it is very less sensitive, 10% or 18%. So we go for the next. Can we use a BL-BLI combinations, piperacillin, tazobactam, for patients with urine? Yes, we have to do. We have no other choice. We sometimes go for BL-BLI to treat a patients of urinary tract infections who are admitted in the ward, and then ultimately, in some people, they prefer to go for meropenem. We discourage. We don't want them to use carbapenem in the ward setting. Same patients, along with when they're having E. coli and then when having Klebsiella, you can see the scenario has not changed much, and we don't have much choice of the first-line antibiotics. So we may have to go for the higher antibiotics. When it is Enterococcus, we do not have much choices. The same patient, when from the ward patient is going to the ICU, I can imagine the patient is now having complicated UTI. Patient is shifted to the ICU, and there you don't have any other choices. You have to definitely go to BL-BLI, piperacillin, tazobactam, ciprofloxacin, sulbactam, or meropenem, if it is E. coli or it is Klebsiella. Just now, Chris was showing on graph. I think Chris will come back, where I can show you the same one, where you can see that the different countries, according to them, their quinolones, the resistance is very high. In that case, they are all healthcare associated urinary tract infections. They are BL-BLI also. There is in case of Asian countries and South American and African countries, definitely the resistance pattern is very high. Carbapenem, what is shown here is not that alarming, but it depends on the number of hospitals and patients that it has been collected. So I can tell you that start antibiotic treatment for complicated urinary tract infections, but you have to have a hospital antibiotic policy. And then you have to wait for the antibiotic sensitivity test report and then change. Please don't continue with the same after 72 hours. There is no restriction in starting broader spectrum at the initial stage. You can start with the highest one, but de-escalate as soon as the patient recovers or you have got the antibiotic sensitivity report. Earliest de-escalation is always preferable. This is a case which I have taken from this journal, and you can see the case. It is an emphysematous pyelonephritis case in 87-year male with a type 2 diabetes, long-standing diabetes. Patient was admitted with fever, hypotension, anuria, high total count with high neutrophil count, acute renal failure, CRP is high, abdominal CT. You can see the picture here, rear inside the right kidney and bilateral nephrolithiasis. The patient was treated with meropenem. In our scenario also, definitely I would like to suggest that yes, this patient can be treated with meropenem. But what was catching my eyes, that after 3 days, the patient was afebrile and hemodynamically stable, significant improvement with diuresis and renal functions. Immediately antibiotic treatment tapered down to cefuroxime, second generation cephalosporin and metronidazole for 2 weeks. So that is the key. I want to suggest that you may not be that much fortunate in Indian scenario where you have the cefuroxime sensitive strain. It is the sensitivity strain. It is definitely not from this paper, but suppose this is from my setting. I get E. coli and I get this scenario. In that case, I definitely would like to start with carbapenem, But again, after 3 days, I don't have any choice. I can come back to cotrimoxazole. I can come back to cotrimoxazole. That is a matter of debate, matter of choice. In the clinicians, I would like to talk more about that. But yes, if you have to de-escalate, patient is doing well, patient has no contraindications for cotrimoxazole, and patient is with having fantastic renal functions, you can definitely try to de-escalate. Don't continue meropenem for day 3, 4, 5, 6, 7, 10 days. Actually, what you are doing more harm than the benefit to the patient, which I can discuss further. We don't have much time. So this is the case of, now I am coming to a little complicated scenario. It is the scenario from the blood. I have received the blood sample from a patient, blood culture from a patient is in the ward, and I am growing E. coli, and the patient has the signs and symptoms of complicated urinary tract infection. So I am thinking the patient may have urosepsis. And in this case, I will not look for any other. I will look for BL-BLI combinations and one step higher in meropenem. And then it is difficult to choose. You see that in BL-BLI, if you choose piperacillin tazobactam or ceftriaxone sulbactam, still there is a part. Their sensitivity is 75 to 81%, but still there is a gap that you are going to lose almost 20 to 25% patients because they may not act. Even if you start with meropenem, you have a chance of losing 10% patients. But still, I encourage people, don't get panicked. If you get a patient's blood sample is growing from the ward and it is growing E. coli, you need not have to panic, but you have to think that what is the source of the infection, and how we can treat the source, which is the suitable antibiotic. And if blood from ICU, here you can see the blood is coming from the ICUs, definitely the same choice maintained. If it is a Staphylococcus aureus, we have clindamycin, linezolid, vancomycin. You can choose among these drugs. I want to mention 1-2 points here, that if you get blood from the ICU patients and it is growing Acinetobacter baumannii or Pseudomonas aeruginosa, so we get panicked. We think that, oh my God, it is pan-drug resistant. What we should do now? I should tell you that urosepsis patients, any patients like that, if you get this type of scenario, and you are very confirmed with your clinical diagnosis and microbiological support, the best possible management you should do within the first 1 hour of the clinical diagnosis. And you start with the broadest spectrum combinational antibiotic, that is no harm. If you get Staphylococcus from urinary culture and your microbiologists are very sure, and you are very sure, in that case, definitely there is some source there in the body. So you have to look for the source. It may be pyelonephritis, I agree, but still there may be a source. If it is Acinetobacter or Pseudomonas from urinary culture, you should not get panicked, but all understand that many times it is not a pathogen, it is a colonization or contamination. So you may not treat the patient unless the patient is very symptomatic, and it may be hospital acquired. So prevention and control takes a part, and it should not spread further, and you should find out the source. Clinical algorithm I have taken from this, and here I want to mention which the point I was trying to tell. These are the points: if patient is pregnant, diabetes, renal failure, immunocompromised, kidney transplantations, infections with antibiotic resistance pathogens, hospital acquired infections, just now I mentioned, and there are many other indwelling urinary catheters, functional and anatomical abnormalities, and patient is going into urosepsis. First 1 hour, clinical microbiologist will be of utmost help for you if you consult. And you can send the urine sample, you can send the blood, you can send the swabs, and urogenital, whatever, you definitely know the organism is urogenital tract origin, and you have to start empirical antibiotic therapy. And for that, you have to know your antibiotic policy. And your hospital should have antibiotic policy in place, which will give you a better cure rate. And whenever you get a patient like that with a multi-drug resistant organism, prevention, not the cure. We have come to a stage when we don't discuss more about cure, because we don't have many antibiotics in the pipeline or in our in our control, which we use for the patients to be cured. So prevention, that we can control the infections within the patient. There may not be any antibiotic for cure at present. The infection should be controlled, and it should not, that to spread the multi-drug resistance bugs, we should prevent the spread to another patients who are not infected. That should be the role at present. Just 1 minute. Yeah. So the strategy, we at any time, it is not to argue, not to find faults, not to search that, not to search an escape route. Rather, we should find out how we can curb the antimicrobial resistance at present. There are many policies out there. Infection prevention and control is one of the most, which we completely neglect many times, hand washing and surface cleaning. But antibiotic stewardship, I was hearing Chris, and he was mentioning that antibiotic stewardship. So I would like to know more. So antibiotic stewardship is one of the most important point to handle the complicated or uncomplicated, in whichever way, urinary tract infections or any infections in that way. So how it works? Once upon a time, it was told that restrict antimicrobial use. You should not use all antibiotics at one time. You can restrict few, and you can restrict few antibiotics for some time. Limitations of the formularies and use of certain antibiotics, but restricting antibiotics like cephalosporin, restrict during the ESBL outbreak, carbapenem during the emergence of the NDM or KPC or Oxa strains. At present, it is too late. We have almost lost all antibiotics, and restrictions should have been done almost 20 to 30 years back when we have lost the bus. Then the next policy comes antimicrobial cycling. Can we cycle? So sometimes we use cefepime 6 months or 1 year, and then we don't use cefepime, 4th generation cephalosporin, we go to BLBLI, or then we'll go to the quinolones. Can we do that? It is inconvenient. How long we will use this? How to do this? How to determine how long we can use one antibiotic? So, and it can have cross selections also. Cipro can select imipenem resistant pseudomonas. So it is inconvenient. So what is left with us now to fight antimicrobial resistance through antimicrobial stewardship program is antibiotic policy, the prospective audits and feedback, which I am emphasizing through this lecture, that guidance on prophylactic, empirical, and therapeutic use of antibiotics should be done. And urosepsis, you can definitely have an antibiotic policy in a critical patients. Meropenem and vancomycin can be started upfront, and then according to the sensitivity, you can come down. It is the most suitable in the context at present. We can have that. So the key messages from my talk is if it is a complicated urinary tract infections, first 1 to 6 hours are the most important, and you need a team. You are not alone. You have to find a team and who can decide the most effective management at that moment. Empirical antibiotics can be the broadest spectrum, and it can be in combinations. So one antibiotic may not be enough. You should find very rationally which are the antibiotics from the broadest spectrum you will choose according to the patient's need and the antibiogram. It should be decided according to the institutional antibiotic policy. Right choices can be decided after antibiotic sensitivity report. After 72 hours, wait and see, and then decide again. De-escalate at the earliest opportunity. Otherwise, your next patients, you will keep on having the same problem of facing multi-drug resistance bugs. Patients should be followed up, and that follow-up should be done with the team, which you have already built upon team, and the further management you have to discuss with them. And you have to keep in your mind that cure is not the priority always. Prevention and control may be the priority. So at the end, I will tell you who built the team, who decides antibiotic treatment in complicated UTIs. A team can be of a urologist, microbiologists, ID physicians, general physicians, pharmacists, pharmacologists, and public health expert. We have a team here, and we have a team who decides in Kasturba Hospital about the antibiogram and antibiotic policy, and each infections, it is uncomplicated or complicated, how it should be treated and what policy to be taken at the bedside, and then in the follow-up, how to follow up the patients, and in future, if the situation comes, how we can modify and develop further for the cure of the patient, to control the infections and to prevent the spread. That is our motto. So that is all about my talk, and thank you very much, and wish you a very healthy, happy and safe 2021. I'm happy to take any questions. Thank you very much.